Welcome to the deep dive. We are jumping right in to a really fascinating corner of diagnostic technology today. But first, we want to make sure we acknowledge our source here. The material for this deep dive was developed using Dr. Raju's excellent YouTube series. Specifically, we're drawing from his insights on, advanced endoscopy technology and pharmacology.
Yeah, it's pretty technical stuff, but we're aiming to translate the key takeaways for you, focusing on how some really cutting-edge screening is actually made possible by, well, surprisingly low-tech methods.
Right. So our mission today is a deep dive into something called chroma endoscopy. Sounds a bit sci-fi, maybe, but it's really about the practical use of specialized chemical sprays, basically painting the inside of your body in a way to make problem areas stand out.
Exactly. I mean, an endoscopy itself is a vital tool, no question,
But
but its limitation often lies in just visualization, seeing things clearly. These subtle, flat, precancerous lesions, the earliest signs of potentially major trouble, they're often completely missed.
especially if they're in tricky spots, or maybe the patient is already known to be high risk.
Precisely. Especially then.
So, if a standard endoscope gives the doctor, let's say, a general look at the landscape, these sprays are more like giving them a high-resolution map. They almost force the dangerous areas to um, reveal themselves. We're going to talk about specific dyes and even, get this, common household items.
Like vinegar.
Vinegar, yeah,
Yeah.
that temporarily stain or alter the tissue so these invisible threats become visible.
It really is about leveraging simple chemistry to get, high-stakes diagnostic accuracy. It's quite clever.
Okay, let's unpack this. Let's start with the blue team, shall we?
Quite clever.
Methylene blue and indigo carmine, these are specialized blue dyes. What critical role do they play, and who are they primarily used for?
Okay, so these dyes are foundational for enhancing colon screening. Really important there. And they're targeted almost exclusively at two very specific high-risk groups. The first group, that includes patients with long-standing inflammatory bowel disease, so ulcerative colitis or Crohn's disease. After about, say, 8 to 10 years living with IBD, the risk of developing dysplasia, these precancerous changes, it goes up significantly. So you really need a targeted full mapping of the colon lining.
Okay, that makes sense. Long-term inflammation increases risk. And the second major group, the ones benefiting from this blue dye approach.
That would be individuals with familial cancer syndromes, primarily Lynch syndrome. Now, what's critical about Lynch syndrome is that the lesions linked to it, the potential precursors to cancer, they're often flat, very subtle, incredibly hard to spot without some kind of enhancement. And you have this high cancer risk running across generations in the family, so enhanced detection is, well, it's mandatory.
Got it. So these aren't patients looking for the typical obvious polyp. They're searching for those really insidious flat ones that are easy to miss. Now, logistically, how does a physician actually get this stain applied, throughout the entire large intestine? Seems like a challenge.
Well, there are two main ways to do it, logistically speaking. One, you can use a dedicated spray catheter. It's thin, goes right through the scope channel. Two, and this is often more efficient, you can actually use the water jet system that's already built into the scope. You just put the dye material directly into the water canister that feeds the jet.
Using the water jet, that sounds pretty ingenious, efficient. But I noticed in the sources, there's a big variance in the mixing volume mentioned. Sometimes 250 milliliters, sometimes up to 1,500. Why such a wide range?
Ah, right. That variance usually depends on the specific equipment setup, the type of scope, the size of the water bottle or container attached to that water system. It can vary, but regardless of the total volume, the goal is consistency in the concentration. You always mix 2 vials of the blue dye into the water.
Okay, 2 vials, but how does the doctor know they've hit the right concentration then, given those different volumes? Is there a trick?
The visual goal is the key. It's the ultimate check. The final mixture, whether it's in 250 milliliters or 1,500 milliliters, it must achieve this specific light blue, sky blue color.
Yeah.
If it's too dark, well, it just obscures everything. Too faint, and you lose the contrast effect.
Right, that makes sense. Goldilocks color.
Exactly. And then, once the colon is optimally clean, and I mean really clean, that's non-negotiable, the physicians start spraying the dye once they reach the end, the cecum. Then they work backwards, spraying as they withdraw.
Moving backwards.
Moving backwards, yes. And then they suction off the excess fluid. And that process, it reveals the architecture, the fine details of the mucosa. It highlights lesions that would be completely flat and essentially invisible otherwise. The dye sort of pools in the abnormal areas, or it's absorbed differently by those cells. You get immediate high contrast.
Wow. So that subtle difference in how a simple light blue dye interacts with the tissue, that tells the whole story down in the colon.
Amazing.
Okay, let's shift gears completely now. We're moving at the GI tract to the esophagus, and we're going to talk about a substance we might associate more with, like a first aid kit, Lugol's iodine.
Lugol's iodine. Typically, it's used in a 1.2% solution, and this is the standard bearer, really, for screening for squamous cell cancer of the esophagus. This type of cancer, it's often linked to long-term exposure to certain irritants or chronic issues.
Okay, and the mechanism here is what really caught my eye. It's fascinating because it's based on a fundamental aspect of cell chemistry. Here's where it gets really interesting. It leverages what the cell stores inside it.
That's right. It's entirely dependent on carbohydrate storage, glycogen. So during the upper GI endoscopy, the EGD, the physician, sprays the Lugol solution. They start usually at the bottom near the stomach, the GE junction, and coat the entire esophageal lining moving upwards.
And the key distinction, the magic, if you will, comes from glycogen. Normal squamous cells, the ones that should be lining the esophagus, they are packed, absolutely rich in stored carbohydrates, glycogen.
Exactly right. And iodine readily interacts with glycogen. It binds to it. So those normal, healthy cells, they soak up the iodine and turn this dark, unmistakable brown color. Very clear. But precancerous or cancerous cells, they've changed fundamentally. They've either used up their glycogen stores or they just lack them altogether as part of their abnormal state.
Which means the dangerous areas fail to react with the iodine. They just don't take up the stain. So you end up with this landscape that's mostly dark brown, but with these highly visible white or unstained areas basically screaming, look over here.
Precisely. Those non-stained patches are the critical findings. They are the immediate targets for intervention. Now, this might involve taking a small, precise biopsy just to confirm the diagnosis at the cellular level. Or if the area looks clearly abnormal and seems contained, it might lead directly to considering resection.
And when you say resection, you're talking about those minimally invasive removal techniques, like endoscopic mucosal resection, EMR, or maybe endoscopic submucosal dissection, ESD.
Yes, exactly. Those are the techniques. Much preferred over major surgery, obviously. If we can spot that lesion early, thanks to this high contrast stain, we can often remove it entirely right through the endoscope, which potentially prevents the need for much bigger, more invasive surgical interventions later on. It essentially turns the absence of a chemical reaction into an incredibly powerful diagnostic signal. It's quite elegant.
That is brilliant chemical triage.
Yeah.
Really clever stuff. Now, for our final chemical agent, we're looking, as you mentioned, in the pantry again, acetic acid, common vinegar. This seems, well, wildly out of place in advanced diagnostics, doesn't it?
It does seem that way, but acetic acid is surprisingly potent in this context. We know it as standard vinegar, sure, but in diagnostics, it actually plays two crucial roles.
Okay, let's start with its primary use then, which is screening for dysplasia in Barrett's esophagus.
Correct, Barrett's esophagus. So when acetic acid is sprayed onto Barrett's tissue, that's the abnormal lining in the esophagus that can sometimes precede cancer, it causes this temporary effect. It's called acetowhitening. The acid basically causes a temporary coagulation of the surface proteins, which makes the tissue turn white or sort of cloudy for a short time.
Okay, so the whole surface looks whitened initially, but the trick, I'm guessing, is about timing, how long it stays white.
Absolutely. The key difference lies in how long that whitening persists. Healthy or at least non-dysplastic Barrett's tissue, it holds on to that whitening effect for a fairly predictable amount of time. But the dysplastic cells, the precancerous ones, they have altered protein structures, different permeability, and they lose that whitening effect much, much faster.
Ah, I see. So once that temporary cloudiness starts to fade, the areas that revert back to their normal appearance the quickest, the ones appearing non-stained against the still white background, those are the problem spots.
You got it. Those fleeting, non-staining areas are identified and then targeted for biopsy. This lets us confirm dysplasia that was probably completely invisible under standard white light endoscopy just moments before. It's really an elegant way to use a simple acidic reaction to pinpoint functional cellular changes.
Very clever. And you said acetic acid has a dual role, right?
Okay.
There's a secondary use.
Yes, back down in the colon again. What's fascinating here is acetic acid can be quite useful there too. Specifically, it helps assess the true extent of subtle serrated adenomas, those tricky flat polyps again. These flat polyps are notoriously hard to define sometimes because they often blend right in with the surrounding mucosa, and they might be covered in a layer of mucus.
Right. So if a physician sees one of these serrated adenomas but isn't quite sure where the outer edge, the margin, actually is, they spray the vinegar.
That's exactly right. The temporary acetowhitening effect does two things. It helps clear away some of the surface mucus, and it provides better definition of the lesion's borders against the normal surrounding tissue. This is really crucial for guiding the removal process, making sure the entire polyp, including the margins, is taken out, helps reduce the chance of it recurring. So yeah, it aids high precision visual confirmation in two completely different parts of the digestive tract. Quite versatile for simple vinegar.
This is truly astonishing. Okay, we've covered these powerful yet fundamentally simple chemical tools. Let's try to synthesize this for the listener. Bring it all together.
Sure. So we covered the blue dyes first, methylene blue and indigo carmine, used specifically in the colon, mainly for high-risk patients like those with Lynch syndrome or long-standing IBD. And these dyes work by differentiating tissue architecture, pooling differently on abnormal spots.
Then we moved up to the esophagus with Lugel's iodine. That's the reverse stain, isn't it? It highlights danger by staining the healthy cells dark brown because they have glycogen, leaving the potentially cancerous cells untouched, unstained, white for squamous cell cancer screening.
Correct. And finally, acetic acid, just common vinegar, used in the esophagus for Barrett's, identifying dysplasia through that temporary whitening and quick reversion phenomenon, and also used down in the colon, secondarily, to help define the tricky margins of flat serrated polyps.
And the big logistical takeaway seems to be that whether it's a blue dye, an iodine solution, or just plain old acid, all these materials can be delivered efficiently, either via a dedicated spray catheter or often just using the scope's built-in water jet system, as long as that concentration, that color, looks right visually.
It's a really neat and efficient system, yeah.
So why does all this chemistry, this cell staining, matter to you, the listener? Why should we care that doctors are essentially, painting our insides?
Well, because this fundamentally shifts the screening paradigm. It's about precision. It ensures that those subtle, flat threats, the kinds of lesions that can take years to develop into life-threatening cancers, especially in high-risk families or situations, are intercepted much earlier, at their most treatable stage. This enhanced visualization capability, it translates directly into potentially avoiding more aggressive treatments down the line and achieving better long-term survival outcomes. It's really a fundamental step forward in early detection, all relying on simple, proven chemical principles.
So what does this all mean then? I guess it means that fundamental chemistry, the way iodine reacts with starch, or the temporary way acid affects proteins. That's the secret weapon, in a way, in advanced diagnostics today. It kind of proves that sometimes the most effective tool in medicine isn't necessarily a billion-dollar imaging machine, but maybe just the right chemical solution applied with precision.
Absolutely. And if we connect this to the bigger picture, this reliance on cell chemistry, on these simple but powerful staining techniques, it really showcases how effective these, you could say, low-tech but high-precision visual clues are in the ongoing fight against cancer risks, particularly inherited and chronic ones. The basic chemical blueprint of the cell itself is telling us exactly where the danger might be hiding. It turns a general look around into, well, almost a microscopic mapping operation.
Something to think about next time you look at a bottle of vinegar, maybe.
Yeah.
That is our deep dive for today. We'll catch you next time.